welcome. Thank you for being here. We're so excited to have the second webinar in the PWN Policy Agenda webinar series on advancing universal health care. If you weren't able to make it to our last webinar in this series, it was on ending criminalization, and it's available on PWN's website, pwn-usa.org, and I encourage you to take some time and check it out. Just a little logistics to get us started. Everybody who is joining is going to start on mute. If you have any questions, please feel free to type them into the chat box or into the question and answer section. We're going to be moderating that to ensure that no one's questions get lost. Or if you want to hold on to your questions until the end, you can write them down, and we're actually going to have a time for some verbal Q&A at the end. All you have to do is raise your hand, I'll take you off mute, and then you can ask your questions to our expert panelists. Just so you know who's talking at you, I am Kelly. I am the If, When, How Reproductive Justice HIV Fellow with Positive Women's Network. And also moderating will be Nana, Positive Women Networks USA's Executive Director. And now I'm going to turn it over to Nana.
Great, thanks so much. Hi, everybody. Welcome again. As Kelly said, I am the Executive Director of Positive Women's Network USA. I'm Nana Khanna, and I have been with PWN for about 10 years since we were founded. I'm one of the founding members. For those who don't know, Positive Women's Network USA was founded by 28 women living with HIV back in 2008. And so I'm one of those initial founding members and came on as Executive Director about 5 years ago. And I'll tell you a little bit more about PWN in a minute. But before that, I want to introduce our fabulous panelists to you. We have a really fierce and exciting lineup of experts on the line with us today, and we're so honored to have them here with us. So we have Candace Gibson from the National Health Law Program. Candace is a staff attorney in Washington, D.C. at the National Health Law Program's office. She focuses on reproductive health issues in Medicaid and in private insurance. Prior to that, Candace was at the National Latina Institute for Reproductive Health, where she worked a lot on advocacy and cross-mobilization efforts around religious refusals and the implementation of the Affordable Care Act, which we all know is really important to our communities, and we're going to talk about that today as well. Also, Candace brings a background working in refugee and immigrant communities on healthcare reform and looking at eliminating health disparities around that. So really pleased to be joined by Candace today. You're going to get to hear from her in just a little bit. Next, we have Maxx Boykin, and I know many of us are very familiar with Max's amazing work. Maxx is currently the National Community Organizer at the Black AIDS Institute, focusing on building up BAI's policy, advocacy, and mobilization work, especially through the Black Treatment Advocacy Network. And Maxx comes to this work as an organizer, an activist, and a believer that we have to be the change we want to see. Before joining BAI on the staff team, Maxx was the manager of organizing at the AIDS Foundation of Chicago and helped to run the HIV Prevention Justice Alliance, which you may be familiar with. And then finally, we have Katie Robbins. Katie is the director of the Campaign for New York Health, which is a statewide campaign advocating for single-payer universal health care in New York. Super exciting work, and Katie is sort of like one of the premier national experts in thinking about how to really move different kinds of healthcare access at the state level. So we're really, really pleased to have Katie joining us today. She used to be a national organizer with Healthcare Now before the Affordable Care Act was passed, and kind of helped to move a lot of that process as well. So Katie, thank you so much for joining us, and Katie's in New York City. So let's see, we can go to the next slide. So I want to talk a little bit about how we got to where we are. Wait, is there another slide before that? No, okay, thanks. The mission of Positive Women's Network USA, we are a national membership body of women and folks with trans experience living with HIV. we're across, across the US. We also have, in addition to our national membership base, we also have 6 chapters, and we have state leads in another 13 states. So we are actively organizing in, somewhere around 15 to 20 states at any given time. Supporting state level and local work, as well as federal advocacy work. And our mission is to prepare and involve women living with HIV in all our diversity, in all levels of policy and decision making. And so what that means is we are a constituency-led organization. We are run by women living with HIV. Our board of directors are 100% women and folks of trans experience living with HIV. Our staff are majority women living with HIV, majority women of color. And so our commitment is to be reflective of the communities that we're representing, and to really make sure that our voices are at decision-making tables where decisions are being made about our lives, right? And the lives of our communities. And so particularly we focus on elevating voices, leadership, and participation from communities most impacted by the epidemic. So that means Black, Latinx folks, folks of trans experience, low-income communities impacted by HIV, et cetera. And so, in the last couple of years, we kind of have gone through a large, internal process. I know all of us had some concerns after the 2016 election, to say the least. And we were coming out of an administration that had been pretty responsive on a lot of HIV issues, and we knew that, and where we had been really moving a lot of progressive policies at the federal level. After the 2016 election, it became really clear that we were going to be faced with a very different context, to say the least. And so following the 2016 election cycle, Positive Women's Network, we already had a policy agenda that we were sort of moving primarily at the federal level. But after that election cycle, we went through an intensive process to kind of relook at where there were opportunities for us to have the best impact, building off the work we had already done. And so we talked to, hundreds of our members through surveys, listening sessions, and conversations. We talked to external stakeholders and our broader constituency, because it was really clear that we were going to be facing grave threats to the very, not just healthcare, although that's a lot of what we'll be talking about today, but really the human rights and dignity and right to survival of our communities. And so in the midst of, the last couple of years of dangerous, regressive policies, we have been fighting back, but we're also committed to pushing and advancing a transformative vision for change. And we know that that is entirely possible. And we know that, in fact, many people are hungry for it, are hungry for real progressive policies, real safety for our communities, real dignity for the people we are serving. And so, so we really used the last couple of years to think about what were the opportunities to push forward new systems of power, transformational systems of power, and progressive policy change that meets our needs holistically and equitably. And so, as a result of a lot of the conversations we had with our constituency, we developed a new sort of updated policy agenda. And so these are our new policy priorities. These are sort of like large buckets of work under which we organize our both reactive and proactive work at the federal, state, and local level. And so these are basically the 6 things that we are primarily pushing for. You can read a lot more about them at the link on this slide. And so we released this policy agenda in July of 2017. Basically calling for advancing universal health care for all our communities. Kelly's going to talk more about what that means for us. Economic justice for people living with HIV, so the right to be financially secure, fed, have access to the services and benefits we need to survive. Sexual and reproductive health rights and justice for all people of all genders, regardless of our choices around family creation. ending criminalization in all its forms. So kind of starting with HIV criminalization, but really broadening the lens out from there to harm reduction and decriminalization of sex work and drug use. And we did have a great webinar on that just a few weeks ago that you can find at the link I posted in the chat box. Also advocating for trans rights, safety, and justice, and ending violence against women living with HIV. And so as part of our launch of this new policy agenda, we are hosting a webinar on each of these sort of broad topics that highlight some of the major opportunities we see and that we've heard from allies and accomplices we work with are poised for impact, right? So things to be aware of, things where we think we can all collectively really make a difference over the next couple of years at the state and federal level. And so I think I'm turning it back over to Kelly to talk a little bit about what we're going to be doing today.
Thank you, Nana. So for our webinar today, we have 4 main objectives. The first is to increase our understanding of recent attacks on healthcare and the potential impact that that could have on our communities. We're also going to learn about universal healthcare and the promise that single-payer systems hold. We're going to learn about how organizing works, learn how we protect healthcare and win access for all. And then, as always, we want to be action-oriented. So we are going to highlight some policy solutions and some actions that you can take to advocate for improved access to healthcare in your communities. As Nana had said, we do have the universal healthcare section of our policy agenda. And there you're going to find our vision, which is already up here, but I'll just tell you quickly, it's that all women living with HIV have access to high-quality, culturally relevant, non-stigmatizing, and affordable healthcare and services, regardless of sex assigned at birth, race, immigration status, or ability to pay. Universal healthcare is a big part of that, and I'm going to go ahead and give you a hint. In the US, we have not achieved PWN's vision. You're going to hear a lot more about the ways that we haven't yet achieved it and some possible policy solutions going forward. But I will say right here that the Affordable Care Act has done a lot to expand access to care for women living with HIV by doing things like reducing discrimination, improving quality and consistency of care, and reducing financial barriers. But there are real limitations. 14 states, most of which are in the US South, have not expanded coverage. The law does not provide coverage for undocumented immigrants. It has limited coverage for other immigrants, and it maintains the federal ban on abortion coverage. So it's imperfect, but made progress. And yet in the last couple of years, we've also seen the actions on the state and federal level that threatens to undo the progress that has been made. As we heard in the State of the Union most recently, apparently Trump and the Department of Health and Human Services has made ending the HIV epidemic a priority. It's a goal that everyone shares, but we know that we cannot get there without a robust, non-discriminatory healthcare system. But, you know, take heart and take action. So when you look into our policy agenda, what you're also going to see are some concrete recommendations. We have some listed up here. They're to state, federal, and local actors and ways to improve equitable access to healthcare. So things like creating single-payer healthcare systems, which you're going to learn so much more about on this webinar. Expanding access to healthcare for all immigrants, regardless of immigration status, and for all states to expand Medicaid programs. Throughout the course of this webinar, you're going to hear more from our expert panelists about what these policies are and why it's so important that we push for change. Along with each of these webinars, PWN is going to be releasing a fact sheet to guide your advocacy and help you inform people in your communities about these issues. So you can see our universal healthcare fact sheet. Part of it is here. It's also in the link below. I encourage you to go and do a deep dive into it. I'm going to give you just like the big takeaway here, and it's that healthcare is a human right, and universal healthcare is essential to promoting that right. So you're going to learn in the fact sheet a little bit more about what universal healthcare is, some of the models that different nations have used to achieve universal healthcare. You'll learn about the single-payer system, which is one of those models and which you're also going to hear about on this webinar. It's gaining a lot of popularity in the US. And so there are a bunch of recommendations on that fact sheet, including recommendations for 2 bills. One is in the House and one is in the Senate. They're colloquially known as Medicare for All. So we'll talk a little bit about that. But I encourage you to look through those fact sheets, dig into it a little bit more. And we have a long list of resources that's available to everyone on this webinar. You'll see it at the end. So for now, I'm going to stop sharing my screen and turn it over to Candace to get us started.
All right, thanks, Kelly. All right, thank you again to the Positive Women's Network for inviting me to be part of this illustrious panel. Thank you again, Nana, for the lovely introduction. And as Kelly mentioned, I'm Candace Gibson. I'm a staff attorney on the Reproductive and Sexual Health team at the National Health Law Program. And so the focus of my remarks are going to be on the Medicaid program itself. So before I go into that, I'll talk a little bit about the National Health Law Program. We're a national nonprofit dedicated to securing the health rights of those in need. We do this work through policy advocacy and litigation at the state and federal levels. And we're actually about to celebrate our 50th anniversary. So we've been around a long time. So what am I going to talk about today? My goals really are to give you a baseline of what the Medicaid program is, what are Section 11 of 15 waivers, which the Trump administration is currently misusing this type of authority to undermine the Medicaid program, which you may have heard quite a bit about already, and also how you can resist these state and federal efforts to undermine the Medicaid program through the use of these Section 1115 waivers. I also want to add that this presentation, I've adapted this presentation from a presentation that I've done collectively with In Our Own Voice, the National Black Women's Reproductive Justice Agenda, the National Latina Institute for Reproductive Health, and the National Asian Pacific American Women's Forum. And I think also having understanding of Medicaid is critically important as we talk about single payer and the conversation moves forward about universal coverage in this country. Just from my own experience about talking to federal policymakers about the variety of healthcare proposals, oftentimes they don't really know what the Medicaid program is. So it's just really important that we have a firm understanding of the program and how do we protect individuals who are enrolled in the Medicaid program as we move forward to universal coverage or to a possible single payer system. So now I'll go forward and give you a baseline knowledge of the Medicaid program. And a lot of this stuff is going to be wonky, for lack of a better term, but hopefully we can have much more of a rich conversation during the Q&A. So the Medicaid program is a critical health insurance program that's specifically designed to provide coverage for individuals and families living with low incomes. So Medicaid programs vary from state to state, and they operate as federal-state partnerships, meaning that the federal government pays for a percentage of the cost in exchange for states meeting federal requirements. There are no waiting lists to be enrolled in the Medicaid program, and actually Medicaid is considered a property interest under the U.S. Constitution and cannot be taken away without due process. That means for individuals who are enrolled in the Medicaid program, there are a number of protections to ensure their access to care and coverage. Some of these protections include requiring states to process applications for Medicaid enrollment quickly and to enroll people in coverage promptly. Individuals who are qualified can enroll in the Medicaid program at any point of time during the year. Additionally, as I mentioned before, because this is a property interest under the U.S. Constitution, there are due process rights for Medicaid enrollees. So that includes the right to adequate notice and also hearing. If they're either applying for rights and their application is denied, or certain benefits and services are being reduced or eliminated. And then there are also financial protections. So under federal law, premiums are generally prohibited for individuals who are living with incomes below 150% of the federal poverty level. And states can use co-pays, but these co-pays have to be very small in amount. So also, as many of you know, Medicaid is an essential source of coverage for reproductive and sexual health services in this country. Medicaid provides coverage of family planning services, STI testing and treatment, and pregnancy-related care. The Medicaid program covers more than half of all births in the United States and accounts for 75% of all public dollars spent on family planning. And some of the other mandatory benefits that Medicaid includes are, physician services, home health care, and a number of services on this slide. I will also, because I forgot to do this on the slide, to spell out what EPSDT means. It means early and periodic screening, diagnostic, and treatment services, and which this ensures is a robust coverage benefit for children and youth who are under the age of 21 in the Medicaid program. This ensures medical, vision, hearing, and dental screenings, including age-appropriate health education. So this is also considered the gold star of care for pediatric care in the country. And additionally, under the Medicaid program, individuals have the right to transportation to medical care, because we know that transportation is a barrier to accessing care for many of our communities. We also know that Medicaid, as my colleagues at Planned Parenthood would say, is a women's health program. Overall, women make up the majority of Medicaid enrollees, and Medicaid disproportionately covers women of color because of the discrimination and interlocking systems of oppression that women of color have faced in this country. And that's why it's such a critical source of coverage for people of color and especially women of color. I will also say too that the graphics comes from the Guttmacher Institute, and some of the stats on the side about the number of Asian communities who are covered under the Medicaid program come from the National Asian Pacific American Women's Forum. And as the Positive Women's Network knows, Medicaid is the largest source of coverage for persons living with HIV in this country. In 2014, Medicaid covered 40% of individuals living with HIV. In addition, Medicaid plays a critical role in ensuring coverage of gender-affirming care. You'll see on this slide, this is a map from the Movement Advancement Project, which provides numerous research and data about a variety of LGBTQ issues. The green states are those states that have where their Medicaid agencies have explicit policies of coverage of transition-related services. The orange states are states that have what we call categorical exclusions of coverage. And you see the beige states are the states that just don't have any policies or we're unaware of them. The National Health Law Program's view is that states must provide Medicaid coverage of gender-affirming care, or else they're in violation of the Medicaid Act, of Section 1557, which is the non-discrimination provision of the Affordable Care Act, and the US Constitution. So as you see on the map, 17 states and the District of Columbia have state Medicaid policies that explicitly cover health care related to gender transition for transgender individuals. So as we also discussed earlier in Kelly's remarks, the Affordable Care Act expanded the population eligible for the Medicaid program. So Medicaid expansion allows uninsured adults whose incomes are at or below 138% of the federal poverty level to enroll in coverage. Prior to the Affordable Care Act and Medicaid expansion, most LGBTQ individuals would not have been eligible for Medicaid coverage. They would have had to, the usual source or path to coverage was usually having a diagnosis related to HIV and AIDS before being able to receive coverage. Under Medicaid expansion, states have to cover 10 categories of essential health benefits. These categories include maternity and newborn care, as well as coverage for all FDA-approved contraceptive methods, as well as preventive services, which includes STI prevention counseling and HIV screening, and mental health and substance use disorder services. And there are also other categories that I did not mention. And Medicaid expansion also played a key role in increasing HIV testing as part of preventive services, and also making sure that individuals living with HIV had earlier access to coverage and care. Unfortunately, as you see on the map, 14 states have not expanded Medicaid. Most of those states are in the South. That's why, I have a lot of appreciation for our colleagues in the South who are trying to do this work. And 37 states have expanded Medicaid. And so before I move forward in discussing Section 1115 waivers, I also just have to mention two policies that are very harmful for individuals enrolled in the Medicaid program, as well as immigrants seeking to apply to coverage for the Medicaid program. And the first policy is the Hyde Amendment. This policy has been around since 1976. The Hyde Amendment blocks federal Medicaid dollars for abortion services, and it's not permanent law, and that's important to know, but it's usually passed by Congress as part of its yearly budgetary process. And this restriction withholds abortion coverage from individuals enrolled in the Medicaid program, except in limited cases of rape, incest, and life endangerment. Despite this ban, 15 states use state funding to provide coverage for all or most medically necessary abortions, and 35 states and the District of Columbia only cover abortions in their Medicaid program that fall under the Hyde exceptions, again, of life endangerment, rape, and incest. 60% of Medicaid enrolled women between the ages of 15 and 44 live in these states with these restrictions, and women of color account for slightly more than half of these women. So the other policy I want to touch on was just the exclusion of many immigrants from the Medicaid program. So because of the 1996 welfare reform law, many immigrants who are lawfully present in the United States and who would be otherwise eligible for the Medicaid program are banned from entering the program unless they reach 5 years of having their legal permanent residency status. Undocumented individuals are unable to be eligible for the Medicaid program. By not being able to access coverage for critical healthcare services, we know then that these types of bans further exacerbate health disparities for communities of color, and particularly for immigrant communities in the United States. So I'll now move on to Section 1115 waivers, which is also very wonky, and we can talk about it more during the Q&A. Section 1115 waivers gets its name from Section 1115 of the Social Security Act. So this is the Social Security Act is really is where the Medicaid program lives in federal statutes. And Section 1115 allows states to request waivers of certain Medicaid requirements in order to test new demonstration projects that promote the objectives of the Medicaid program. Now, the objectives of the Medicaid program is to furnish medical assistance, rehabilitation, and other services to limited income people to help them attain or retain independence or self-care. That's not the exact wording of the statute, but the objectives of the Medicaid program is very important to know, because a number of the Section 1115 waivers that we're seeing that are being proposed by the states are really trying to undermine what are the objectives of the Medicaid program, right, to furnish medical assistance. These waivers allow states to receive matched federal funds in order to provide expanded services and to make program improvements, usually. But we'll see now with this current administration. So in addition, I will say that, and actually to be very quite clear, a number of the Section 1115 waiver requests that we are seeing being approved by the Secretary of Health and Human Services are imposing unprecedented changes to the Medicaid program, including work requirements or work reporting requirements. And could not only will impact current individuals enrolled in the Medicaid program, but could also have a future impact as well. However, again, there are limits to Section 1115 waivers. Congress has said that these waivers have to be experimental. There has to be a robust research methodology to these waiver requests. They have to test out a unique approach. And they have to be, again, consistent with the objectives of the Medicaid program, which is to furnish medical assistance. And also courts have said that, you know, a cut to benefits would not pass muster under the intent of these Section 1115 waivers. So as you'll see on this slide here, these are some of the Section 1115 waiver requests that we are seeing that some of the states have proposed to the Department of Health and Human Services. Some of these requests have not been approved. So for instance, Wisconsin was seeking a Section 1115 waiver request to impose drug testing and screening. That waiver request was not approved. Also, Arizona was seeking a waiver request to put lifetime limits on individuals enrolled in the Medicaid program, and that was not approved either. So for the remainder of my time, I'll mostly talk about work requirements or work reporting requirements, and also elevate lockout penalties as well as waiver requests to eliminate freedom of choice in family planning services, because those are also I also think those are also waiver requests that could be quite harmful to our communities. So work requirements. Since the beginning of 2018, the current administration has enacted this policy shift by inviting states for the first time ever to apply for Section 1115 waivers that would terminate Medicaid coverage to individuals unless they engage in work or work-like activities. So up here on this screen, you'll see the chart that has the number of states that have had their waiver requests approved, and below a number of states who are thinking about imposing work requirements or right now are in the application process. There is an asterisk by Maine because Maine's waiver request was approved, but because elections matter, they got a new governor and they're not going to move forward with implementing their waiver request. So what happens with these work requirements? So individuals who would have to comply with these work requirements would have to meet a monthly minimum of hours, so maybe about 80 hours, maybe 80 work hours for a month. And they also have to show proof that they looked for work, volunteer, go to school, or participate in some type of job training program. Individuals who fail to meet the requirements would be terminated from coverage and locked out. There are certain exemptions, usually for individuals who are pregnant or who are primary caretakers of a person living with a disability, and also students, but these exemptions are usually pretty narrow. Additionally, I want to add that these work requirements, also work reporting requirements, it's another term that our colleagues have been using, really play into ableist language, right? They're calling out able-bodied adults, usually in these waiver requests. And the administration is definitely drawing a line of who is deserving and who's not deserving of help, right? Because most of the waiver requests we have seen that have been approved in the first couple of months in 2018 were really targeted towards individuals who gained coverage under Medicaid expansion, but would not apply to individuals who were part of like the traditional Medicaid program. So what are the implications here for work requirements, right? We know that these are unnecessary and ineffective because they tried to do this before in other public benefit programs. They also prey on historical stereotypes that stigmatize people of color and individuals who have low incomes in this country. And also, most people who are enrolled in the Medicaid program already work, their families already work, so this really is a solution in search of a problem. And for some of the individuals who already work, they are not going to be able to comply with this requirement. So there are a number of individuals that could be affected, right? Individuals who are concentrated in jobs such as construction, retail, the restaurant industry, who have inconsistent work hours, or who have jobs where they do not provide proof of employment. According to the Williams Institute, over 542,000 LGBT adults who have Medicaid as their primary source of coverage could be impacted by these work requirements. And in addition, I think this is a particular concern for the LGBTQ community because we know that this community faces pervasive employment discrimination, so it's harder for them to either find or keep a job. And then for individuals who do qualify for an exemption, they will have to then navigate very confusing and complex reporting and documentation requirements. So at the end of the day, really, Medicaid work requirements terminate coverage for individuals who don't document that they are working, right? So the other two waiver requests I was going to mention are lockout penalties and elimination of freedom of choice. So lockout penalties bar otherwise eligible individuals from receiving health care during a certain period of time. So the length of a lockout period can vary from state to state and ranges from 3 months to 9 months. And lockout periods can apply to individuals who fail to pay premiums, meet work requirements, complete paperwork, or report changes in circumstances. For most Medicaid beneficiaries, being locked out of the program means they have no other viable and affordable health care coverage option. But there is a glimmer of hope. We've, along with some brave Medicaid enrollees from the state of Kentucky, we did sue the Department of Health and Human Services this past summer. So we filed a lawsuit on behalf of 16 individuals in the Kentucky Medicaid program, following the approval of Kentucky's, or following the Secretary of Health and Human Services approval of their waiver request. Kentucky was the first state to be approved for a work requirement, and the state estimated that 95,000 people would lose their health care coverage because of this requirement, although academics have estimated that the coverage loss could be up to 300,000. And really at the center of the case, our plaintiffs contended, as well as with and the court agreed with us, that the secretary failed to adequately consider whether the Kentucky waiver request, which is called Kentucky Health, was likely to assist in promoting the Medicaid objectives. Unfortunately, litigation has restarted in this case because after we had our victory this summer, the Centers for Medicaid and Medicare Services reposted this specific waiver request for public comment, and then they approved the waiver request again without really any changes to it. So now we're in court again. But that's to say that there's hope, that there's people fighting the good fight. And then finally, I want to mention freedom of choice and family planning.
Yeah, if you could just wrap up in about a minute, that would be great.
Oh yeah, definitely, thank you. So Texas, Tennessee, and South Carolina are seeking waivers to exclude Medicaid providers that provide abortion care. This is a clear violation of the freedom of choice provision in Medicaid. So under the Medicaid program, enrollees have the right to seek any willing and qualified provider of their choice for family planning services, and it's a clear attack on Planned Parenthood providers. And I'll just finally say there are many ways to resist these Section 1115 waiver requests. The states have to seek public input. So there are comment periods at the state and federal level. There are public hearings. So I suggest that people really get to know their state Medicaid agency's website to find out this information. And if you have any issues navigating those websites, please reach out to us at the National Health Law Program. We provide a lot of technical assistance to advocates on the ground, and also share your story about Medicaid. Medicaid is a very stigmatized program in this country. We know it's helped quite a lot of people, and so it's important to share your story. So with that, thank you for your time, and I'll turn it over to Katie.
Hey, can you hear me all right? Great. It is such a pleasure to be here with PWN and friends. I'm such a fan of the work. I am based in New York City. I work with the Campaign for New York Health. We are a project of the New York State Nurses Association. And I think because of time, I'm going to actually skip my slides and do kind of a verbal overview, but I can share slides out after the presentation so people can see some of the facts and figures. But I think that'll just help keep the timing on track. So the Campaign for New York Health is a 501c4. We work on advocating for universal guaranteed healthcare in New York State. We are also very supportive of the effort at the federal level to pass Medicare for all legislation. So currently, you know, I go out and I talk about healthcare all the time. And we notice there's a condition that we come up against wherever we are: private insurance-induced stress disorder, or PIST. Frankly, folks who are dealing with plans, whether it's private insurance or Medicaid managed care, are dealing with plans that will increase premiums, you know, double-digit % year to year, will alter networks, changing doctors or hospitals that you're able to go to that your plan will cover services for. It's common that formularies change without any notice. So the drug that you're relying on to manage your chronic condition moves to different tiers, and suddenly your insurance doesn't cover it, or it's a much higher out-of-pocket cost. People are so frustrated by the confusing nature of the healthcare system, even when you have coverage. So principles that single payer advocates are passionate about include universal coverage, but also making the coverage that you have simple and affordable to use. There's some key principles that any single payer healthcare plan should meet, whether it's at the state or federal level. First, any plan that claims to be single payer really needs to cover everybody, regardless of your employment status, your income status, your immigration status, your marital status, all the things that currently basically plug us into different plans that are available. Everyone should be covered 100% of residents in the state or the country. It should be comprehensive coverage. The language that we often see in the legislation is medically necessary care. What I think is very smart about our bill in New York State is that it is written not with like a laundry list of everything that is covered, but rather says anything that is currently covered by Medicaid, Medicare, CHIP, the Children's Insurance Plan, or the state private insurance employee benefits would be covered by the New York Health Plan. I think that's important because, first of all, right off the bat, we're talking about total coverage of reproductive health care, abortion, contraception, no question there. In addition, things like gender affirming surgery, where New York State is one of the states that does cover it in their Medicaid program, we wouldn't see any rollbacks of the kind of gains that have been won in expanding coverage through existing plans. A big win for our work here in New York State is that we pushed the lead sponsors of our single payer bill, the New York Health Act, to include coverage for long-term care and support services from the beginning of implementation. Often policy wonks will say long-term care is so expensive, it will break the bank. And meanwhile, we have a long-term care crisis happening right now. We have an aging population. We have folks who must impoverish themselves in order to be eligible for Medicaid and get long-term care services or home care services. And it's a huge amount of money that is basically uncompensated care. Family members, usually the woman is giving up their career or other livelihood in order to take care of family members who need these services. So it's a really devastating gap in our overall healthcare system, really not talked about enough, and we pushed our state bill to become, fully comprehensive and cover long-term care services. At the national level, my understanding is there will be, as of next week, a national federal single payer bill that Congresswoman Pramila Jayapal is putting forward that is similar in the comprehensive nature. It will include long-term care, similarly to the New York Health Act. So that's wonderful and very exciting that we're having the momentum at the national level too. In addition to covering everyone and for all medically necessary care, any single payer plan should have free choice of doctor, dentist, hospital, qualified provider. This is a relief to folks who have struggled to find providers that are within a reasonable distance to where they live or work. I know I have been on like every different kind of insurance plan. I've had to change my provider countless times over the last 10 years that I've lived in New York. It's very, very frustrating. You don't get the consistency of care, and quality of care goes down when you have to jump from provider to provider. Folks on Medicaid know that, at least here in New York, there's a lot of data backing this up, that if you need specialty care and you are on Medicaid, the wait times can be very long. And this would actually even the playing field so that everybody has the same high quality coverage, the same access to the network, which is virtually every practicing provider in the state. So it will actually improve access to care for specialty care for folks who are on Medicaid. In addition to that, there is a key principle that, the way we fund a single payer program is progressive through taxes. I know I said the T word, and that can scare people, but we're talking about a publicly financed program. The taxes are based on your ability to pay, as opposed to the regressive nature of the private insurance system now, where in New York, it's over $20,000 a year for a family plan. Most people who are getting private insurance through their employer are trading wages and other benefits to support the skyrocketing costs of private insurance. We see that and hear stories all the time of employers, whether they're nonprofit or for profit, struggling to keep up with healthcare costs. So a key component is that it's fairly financed through taxes, and there are no out-of-pocket payments, no co-pays, no deductibles. When you show up at your provider, they do not ask how you are going to pay for the services that you are there to receive. And that is a really important principle. There's a lot of evidence that shows that co-pays can keep people away from necessary care. We're talking about trying to improve access and eliminate the financial barriers that are such a burden right now in the current system. So those are key principles that we would use to evaluate any single payer proposal. There's some big questions, I think, that I'll just talk about quickly in terms of the transition to such a system. The first question we hear is, well, okay, this sounds great. How are you going to pay for it? The reality is, and folks on the call may know, we already spend twice as much as any other industrialized country with universal healthcare, right? So we're already paying for universal healthcare. We just don't get it. We leave about 30 million folks out of the system totally that are uninsured, and many, many more are underinsured and unable to get the care they need because they can't afford the co-pays, deductibles, et cetera. We find that in New York, we have put this issue on the progressive agenda because we have prioritized, of course, having a plan that is feasible. The New York Health Act has been studied several times by progressive economists and also recently the very conservative Rand Corporation. And it does show that you can cover everyone, improve access to care, and not spend any more in total healthcare costs. So we know we have the money in the system now to actually create universal healthcare. But also we have been out talking to people, door knocking, sharing our stories as we struggle to get care in the current system, whether we're uninsured, on Medicaid, on Medicare, or with private insurance. And we're hearing the same stories, whether you're in New York City, in the Bronx, in Queens, or upstate in North Country, Rochester, Syracuse. This is really a unifying issue. People are struggling to get the care they need in the current system, even with as much good that has been done to expand Medicaid, to get people covered. It's simply not just about getting to universal coverage through the patchwork system that we have. We need to improve it for everyone so that you can actually access care without being kept out by financial or other barriers. And that's really the motivation behind single payer proposals here in New York and at the national level with Pramila Jayapal's Medicare for All bill. I'll just say our website and encourage you to check it out. We have a lot of information, FAQs, a testimonials page, and we're working on putting out a report this spring that analyzes the over 2,000 conversations we've had with New Yorkers across the state and telling their stories. So I hope you'll check us out at nyhcampaign.org, NYH like New York Health. And on the national level, you can find out more about the push for Medicare for All at MedicareForAll.org, and that's the numerical 4, MedicareForAll.org. So it was a pleasure talking with you, and I can't wait to hear from Maxx.
Thank you, Maxx. I'm going to share now.
Hello, everyone. As Kelly gets the slides set up here, I'm going to be focusing on advocacy for universal healthcare. How do we try to advocate for something that for some places it looks like it's the next step, it's the next logical step, we're close there, and for some of us, especially us here in the South, it seems like it's so far away. And it looks different in different places, but as we think about this, we have to think about, and it's been said on this many times, healthcare is a human right, and it adds equity, accountability, transparency, universality, and participation. And as we think about how healthcare is a human right, and as someone who truly believes in universal healthcare and what we want to be able to do with this, there's a lot of things that we have to engage with in order to create universal healthcare. So I think Katie and Candace for setting me up, and Nana and Kelly giving them the background of how PWN came to this universal healthcare piece. I am Maxx Boykin at the Black AIDS Institute, and we also have a series of policy priorities, which one of them in our first and major priority is advancing healthcare access. And I'm gonna actually talk a little bit about our journey, but also the journey of actually think about advocacy for healthcare in this country. So next slide, please. I want to bring up something that is very important, and any way in which we think about advocacy, we have to have an understanding of power. And when we think about that understanding of power, click it one more time. Power is the ability to control circumstances or to make things happen. We have a government and system that is able to make things happen. We have legislators able to make things happen, but also each one of you on this call and all of us have the power to make things happen. And we can help control circumstances, and especially as we continue to create people power. Click one more time. And especially for PWN members, this is important. HIV racial justice. Now, our understanding of power is the manifestation of our collective visions into coordinated action. Powers happen when we build together. We have to think about how we're broadening our coalitions, broadening how in which we talk about this, and who we're engaging in this work in order to talk about universal healthcare. Next slide. And the way we do that and increase power is we must organize. Push it one more time, Kelly. The supreme task is to organize and unite people so that their anger becomes a transforming force. You got to organize, right? And I love the fish analogy. When we're talking about advocating for universal healthcare, we're talking about going against the insurance companies who have lots of money. We're talking about going against pharmaceutical companies who have lots of money, and also help fund a lot of the work that some of us are able to do. But understand, and we're also going against the concept of small government, which one political party strongly believes in. So understanding that, how in which we have to do that? We have to engage our folks in coalition building with people, bringing many people together in order to actually get this through. Next slide. And we worked really hard to get the ACA. And what I did not say in my bio is I used to work for Enroll America, which was really working and actually implementing the Affordable Care Act early on when it was starting. And one thing that I did learn while doing it, and I truly care about healthcare. One of the reasons for that is I had an aunt who had cancer for 4 years and passed away. Not because she didn't know about it. She knew about it for 4 years. She did not tell her family and all of us till late during the diagnosis because she had no way to pay for it. And then I lost an uncle in the same state that is also still not past Medicaid expansion due to age-related illness in 2015. I understand that, one, if the ACA was fully implemented, that my aunt would have had access to care. And if the state of Alabama had expanded Medicaid, my uncle would have had access to more resources. So understanding that those policies or lack thereof at times has caused for people in my direct family directly connected to me have passed away. And I understand that without the ACA, many folks would have passed away or wouldn't have had access to resources or would have had to do what my aunt did, was to choose to be able to send her kid to school over making sure that she had medication, right? And I don't think anyone should ever have to make that decision. And that is one of the reasons that we push so hard for universal health care. But something that these wonderful members of PWN and other members in the larger HIV movement did was work their tail off to make sure that they were working to save the Affordable Care Act under the first year of the administration, and have continued to move on that work. We can also think about coalitions such as the PPC, where we've sent emails out about letting folks know to engage their legislators constantly. We did die-ins. we had folks get arrested. We did marches. We did rallies. And we engaged our legislators both locally at home and while they were in DC to make sure that they understood and heard us loud and clear about the ACA fight. And we also saw underhanded things and back into things that made it so that they still were able to take parts of the ACA away. But because of the many of you that are on this call right now and the work of many people across this country, we were able to save many parts of the ACA and not allow for it to be completely taken away. And so I don't ever want us to forget about that and how in which that advocacy was able to change things. We have to understand how those things come together as we continue to move forward in our thinking around expanding access to healthcare. Next slide, please. At the Black AIDS Institute in 2017, understanding the attacks that were constantly happening, we wanted to talk about how in which we talk about healthcare access for Black people. And we did a tour across this country, and one of the things that we found that was very clear when it came down to access to healthcare was states that had Medicaid expansion had better health outcomes in general, but also specifically for people living with HIV, and also were able to bring down the people impacted by HIV through actually having access to that care. One thing that I like to uplift very highly is I compare the last two states, the current state I live in and the last state I live in, Illinois versus Georgia. Illinois has actually the highest unemployment rate for Black people, but still has better health outcomes for Black people than this, and lower HIV rates than the state of Georgia. And one of the big reasons that you can actually tie that together is actually having access to Medicaid expansion. So that was something that we definitely heard. But then we also heard in the states that did have Medicaid expansion that there were still people left out, and there were still people left out of coverage and didn't have access to things. And that also, one of the things that was also very hard for people was understanding how to get access to these things. And with the constant attacks that happen on the state level or local level of understanding how people can get access to healthcare, as we talked about with different House bills that have been brought up, folks not even knowing that their healthcare is being taken away. I was in Missouri last week, and one of the things that we heard, another state that does not have Medicaid expansion, was that in the state of Missouri, they had wiped many people off of their roles, young people, and specifically also women who did not have did not get the mail slip that said like, hey, reading up on getting access to Medicaid. So these people were completely knocked off of it. And so there are also ways in which they are working really hard to keep our folks, the people that are most impacted by HIV, our communities, and specifically when I think about Black folks, from actually getting the care that they actually deserve. And knowing that we all pay into it because we do pay our, because, one thing that the two things you do is die and pay taxes, right? So understanding that, we have to understand, like, what is that next step? What do we do to move forward? Next slide. We've heard so much, and now you're hearing more of we want to expand Medicaid now. We have coalitions such as Cover Georgia. We have many things showing that states that have not expanded Medicaid are wasting taxpayers' money. Big states like Texas, Florida, while other states who have expanded Medicaid are actually like they're saving money and they're also saving lives. But then I want to go back to this piece that has been talked about more and more is healthcare is a human right, and using that as an organizing tool, right? And also something that we especially saw here in many of the southern states was also people having healthcare as one of the top priorities on one of the reasons that they were voting. So understanding how that shows up when we want to talk about how things show up, and as we've seen, voting has consequences. So we have seen where states have tried to move bad plans, and with the change of who was in office, getting rid of those plans, as we've talked about it with Maine, right? And this thought that everyone deserves healthcare. And there's so many people with these stories that have been impacted by not having access to healthcare, and family members that they've lost due to not having access to healthcare, and bringing those constantly up, and really thinking about, like, why don't everyone have healthcare in this country? Next slide. So ourselves, after we came out with the state of healthcare reform in Black America and what needed to be done after seeing an attacks on healthcare. And we did the Black Health Access Tour across the country, talking to folks around, specifically Black folks, and Black folks definitely impacted by HIV on the ground. And we thought to ourselves, for us, universal healthcare was something that we had to definitely talk about, and we have to change it. But we also understand that it's not the immediate next goal, but it is our ultimate goal to have everyone have access to care, because that is truly important. Next slide. So with that, we have to be able to do ongoing campaigns. And a definition of campaign is an ongoing effort towards a specific long or short-term goal, implemented through a strategic plan, coordinated set of actions, and clear messaging. Building a campaign requires us to articulate problems we face, identify specific changes that could address that problem, and demand the specific change we want from the person or people with the power to make that change. This comes from the BYP 100 organizing manual, which I'm also a member of. And one of the things that we really use with the understanding of, like, campaign language, and Katie was able to talk to it briefly in their campaigns that they've done in New York and in other states, is understanding that we have to have clear messaging, we have to have clear goals, and we have to think about it in a way that brings more people in order to face that problem. One of the things that happens when you're trying to do a campaign, or some of the things around the ACA is very complicated. It's 100 some odd pages. Some people are in the care, some people are out of care. There's different prices, different price ranges. People are very confused by the process. And as a person who helped get people signed up to healthcare for many years, I do understand that it is a complicated process. It is important to think about, when moving a campaign or moving messaging, simple messaging is really important to bringing more people in, and also people feeling like they can talk to this subject, right? It's easier to talk about universal healthcare. And yes, there's pitfalls, and we've talked about some of the things that aren't always aligned for folks and people aren't sure about, but they're easier to educate than understanding the hundreds and thousands of pages of the Affordable Care Act and the new laws that they have tried to do to replace the Affordable Care Act over these many years. Next slide. And the next piece, and when I think about campaigns, is a transformative campaign. These steps to a campaign that I have come from the Center for Third World Organizing, led by Carissa Lewis, who used to be out the Bay, but now is in Atlanta. And This was created by BYP 100 member Kay Jones. But as you look at those, campaigns are not something that just automatically end, right? And you have to understand that community engagement is important throughout. And one thing that I actually, when I have a critique of the overall universal healthcare and the single payer movement, has been not as many people of color who definitely are impacted by this and shown of this being at the forefront, and also being just having access to be a part of these larger coalitions. And one thing that we're really working at the Black AIDS Institute is to make sure that our folks are centered as we move forward in talking around universal healthcare. But when we think about a transformative campaign, one thing that's truly important to think about is, what does it mean to ask for everything you actually want? We are typically thinking about we're piecemealing things and having to we'll come to the table with just what we think that they'll give us. That as an organizing tool and as a way in which we advocate, it is, to me, it makes a much better sense to actually ask for everything that you actually want. Ask for everything that you actually need, and we do need access for healthcare for everyone, and understanding it in a human rights framework. It actually helps us understand why everyone needs access to this, that this isn't just an individual thing. This is something that everyone needs. And it actually brings up our overall health as a community, as a country, fully together by actually asking and getting what we actually want. But us understanding, as we think about those steps to a campaign, understanding your power analysis. It is easier to talk about having a statewide universal healthcare in states such as New York, Vermont, I know is talking about it. California has talked about it. We're not as close to that in the state of Georgia and many of the other states in the South, right? It is more now trying to ask for Medicaid expansion. But still, in the coalition and in the fight of getting more people covered, understanding that our ultimate goal is still to have everyone having access to healthcare. But right now, we are trying to understand, and with the power analysis of what we're dealing with and the targets that we see currently, that asking and understanding of Medicaid expansion is important. And I also want to actually think about, next slide, please. The importance of building coalition, and I definitely want to shout out HIV Racial Justice Now, and also the Bully, the Black United Leadership Institute, but for being both coalitions that are national in scope, and centering people most impacted and communities of color, to make sure that we are actually saying and doing what actually needs to be done, and having a racial justice framework in everything that we do. To me, universal healthcare and racial justice are two very tied things together. And as we think about building coalitions and thinking about how we move together, bringing those folks in order to have those hard conversations and centering the people most impacted, but also thinking about how we increase the ability of who we are able to target, who we're able to reach, and then who are we able to actually engage in changing the forms that we want to see. So forming strong coalitions that are broad-based, that connect people that are not just in the HIV sector, but also in many other. I helped create a coalition in Chicago, Resist, Reimagine, Rebuild, which has 33 organizations, mostly people of color led. When I say mostly, it's like 95%. And with that also, but bringing in different folks from labor movements, from different social justice backgrounds, immigrant rights, criminal justice reform, all of them coming together to actually talk about how do we actually build power in order to get all the things that we need in the city of Chicago and Cook County. And actually the things that they're adding to that is adding a health equity lens into it, understanding that health organizations are also coming to the table, or health organizing institutes, and talking about how in which we talk about all of the things that we need right now. And that actually, I think, in some of those broad-based coalitions is how places like Illinois just got passed 5 for 15. This is how these things are actually done. So we can also look at different movements and different wins that we've seen across the country in different states as ways to actually show us how to win this large fight and push legislations, which was not just a legislative fight. It was not just getting people out to vote. It was not just raising consciousness. It is actually all of those things that actually has to be done in a campaign in order for us to actually win and also be sustainable, right? The difference between ACA wasn't as sustainable because people did not understand it, and there was not clear messaging on folks that did support the ACA, including myself, in getting that fully understood for everyone to be. So when there are attacks on it, people are like, whoa, I need this and I need it to stay. And because of some more education that we did in years following up, we've actually been able to keep the ACA. And I think also with you seeing more presidential candidates talking about universal healthcare, that is also something that we can do in order to change things. Next slide. And when I think about how in which we are able to organize and move forward, rallying is great, but we need to make sure that it's organized and we're actually having clipboards and we're collecting people's signage so we can move forward. Don't underestimate the importance of political education and educating our folks constantly through this. Like everyone that you're getting in connected to this needs to go through this webinar, needs to talk about it and have conversations about it. Keep up to date with new policies that are coming forward. Support existing campaigns. Healthcare is a human right. Medicare for all. There's many different campaigns, so support those existing campaigns and staying on message with them. Don't limit yourself to one form of action. One form of action is not going to get us the change we need to see. We actually need to do multiple forms. And then again, important for me, centering the leadership of the most impacted. Actions that don't center them are actually endangering them. Remember that as we move forward. And that'll wrap up for me. And I think we're on questions.
Awesome. Wow. I just learned a lot from all of you. I'm so inspired. I know there are probably questions and folks are probably wanting to engage in some discussion around this on the line. So just a reminder to our attendees that if you do want to be unmuted to speak, you can just kind of scroll over your name on the participants window and raise your hand. Okay, I see we have a couple hands popping up. So we're gonna let the hands come up and go through and unmute folks. And in the meantime, while folks are getting unmuted, wow, I have so many questions, but I'm gonna start with just one. So Katie, I was wondering if you could talk a little bit more specifically about what it has looked like to be trying to move single payer in New York. Like, let's, tell us a little bit more about the legislation and what it's looked like to get there, and what are some opportunities you would share with state level advocates thinking about trying to do this?
So in New York, we've had a long history of pushing single payer legislation, and it was largely driven by a very provider-centric campaign since the early 90s. So it tended to focus on policy analysis and research without a power analysis like Maxx laid out. About 5 years ago, we came together with the Nurses Union, as well as some of our amazing coalition partners, Statewide Senior Action, Commission on the Public Health System, which serves communities of color in New York City, and key upstate groups to say, if we want this to move forward, we need to have a truly statewide movement that rejects the idea that this is just New York City liberals who want single payer healthcare, but that this is truly an issue that is resonating across communities all over the state. And since then, we had a driven effort to do base building through outreach, canvassing using the Healthcare Rights and Access Survey. We did a number of anti-racist trainings with our membership to think through how we are talking about healthcare, how we're doing our organizing, making sure that instead of the model that I think had been used for a long time with single payer advocates, where you would kind of go out and talk at people about how great the concept of a single payer system is, rather doing an exchange about what, one-on-one exchanges about what our experiences with the healthcare system has been a really dramatic way to be able to build the base and bring people into this work. Because we interact with healthcare in so many different ways, it really does involve that kind of meaningful conversation to bring people into the base. So that's been done all over the state. We have 13 local organizing committees that meet regularly, think through what their local context is. A lot of what the tactics involve is, making sure that we're having conversations with people, capturing people's stories about what they're dealing with in their healthcare crisis, and then getting those folks to pressure their legislators to do the right thing and get on board with the New York Health Act or Medicare for All at the national level. So we're at a moment in New York where, you know, for the first time in the November election, the state Senate actually flipped from Republican to Democratic control. We have not quite a supermajority, but really close to Democrats. We've actually passed our state single-payer legislation 4 years in a row in the Assembly. So the Assembly has been on record in favor, and we had, you know, a majority of the new Senate either as co-sponsors or actually ran on the New York Health Act as part of their platform. So it was exciting to see that we broke through one of the barriers, which was you could never, you know, the conventional wisdom around this issue would say you can't win an election outside of New York City on single-payer healthcare. And actually it was one of the galvanizing issues throughout the state, and in the burbs, Long Island, Hudson Valley, upstate, you know, candidates actually won, not just saying they support it, but actually sometimes the number one issue that they ran on. Like, they were motivated to run because of healthcare and supporting the New York Health Act. So now we're seeing the powers that be come together to try to kind of tamp down expectations on healthcare. The governor actually pretty swiftly has set up a commission of experts to look at how to get to universal coverage, but emphasizing commercial health insurance plans would be at the center of that. Unfortunately, you know, there had been discussion about expanding public programs in New York State to the undocumented population and improving subsidies to those who couldn't afford private plans. And the governor has kicked those down the road too with this commission. You know, we in the single payer movement have partnered with coalitions like Coverage for All, pushing for bringing undocumented folks into the system who are currently not eligible for any plans, public or private, recognizing that that's one of the ways the opposition tries to divide us in New York and probably nationally too, in stopping universal coverage, you know, winning universal health care by saying, oh, you know, using all the racist language around immigrants. And so we've been very much in line with them, working in coalition on that front too. And where all the health advocates are basically really angry right now with the governor for his actions. So it's going to get real spicy through the budget season, which ends April 1st in New York. After that, we have a commitment from the state Senate sponsor to hold public hearings all over the state on this issue. So we are going to keep mobilizing. We expect to continue passing it in the Assembly, but it really is going to be a huge battle to get this across the finish line. We know we have the people, but we also have an opposition that is very well funded. They have their own coalition now. They're spreading all sorts of misinformation and scare tactics about our proposal. If you want to see what the opposition is up to, you can go to realitieofsinglepayer.com. And you know, it's who you'd expect. The Business Council, which is all the biggest corporations in New York, the insurers. And one thing that is interesting is the insurance companies have been on a charm offensive saying, no, we support universal coverage too. We support covering everybody who's not insured. We just think it's a matter of getting coverage to the 5% of folks who don't have it now. And I don't remember a time when insurance companies were really fighting to cover undocumented folks, right? So they're in this charm offensive mode, saying just give us more public dollars and we'll extend coverage through our plans to more people, which, you know, we're not opposed to people getting more coverage. So we kind of see, look, we're fighting for what we want, and we're seeing incremental steps moving in the right direction through the kind of pressure we're creating, right? We have this left stake on single payer universal healthcare in New York. And so now it's about continuing to move the policy in that direction. If we can't snap our fingers and have it overnight, we may see these kind of incremental steps, hopefully moving in that direction until we can actually implement it. There's more I could go into. The federal government isn't necessarily excited about handing out waivers to states to move to single payer systems. The lead sponsors have developed a plan where this program could actually wrap around existing public programs. So to the beneficiaries, to the people of New York, we would get all the benefits, but there would be some tracking on the back end to pull down the federal funds. You know, we have the transition arguments around employment. The studies show this would be a job boot, you know, because people would get money in their pockets from paying less for healthcare. The conservative RAND study said it would be an increase of about 200,000 jobs, but obviously there's a transition issue because we will see some of the folks who currently are working at insurance companies or in billing and administration. We won't need as many people in a universal public system to do all of that paperwork. So making sure that there's a just transition process for people is critical. All single payer proposals have funding for that, but really pushing for that to be thought out so that it is not negatively impacting the people who would be leaving jobs for the new system is a key priority for us.
Great, thank you. I know we want to make sure we have time for some questions from our attendees as well. Great, it looks like we have a question from Helen. We're going to unmute you. Helen, you're good. You should be able to unmute yourself if you want to ask a question or make a comment. No? Kelly, do you want to ask a question?
I do. Thank you so much, everyone. I have a ton of questions. One I would like to ask actually goes to sort of all three of you in different respects. One of the things that I heard was, so the fight to save the ACA, the push to repeal the ACA was a very sort of obvious attack on healthcare. But I also heard Maxx and Candace talk about more subtle attacks to the Medicaid program, And Katie, I heard you talk about things like how the insurance company is using a charm offensive while still not really getting behind what single payer is. So one of the things I'm wondering is, for someone who is relatively new to the policy space, how would you go about, like, one, seeing these like more subtle administrative maybe attacks to healthcare, and what is maybe one or two tactics that you find really effective as someone who's in this space to push back against them? I think can go to anyone who would like to answer. You're all three.
Oh, Kelly, can you repeat the first part of your question?
Yeah, absolutely. So I think there are some really obvious attacks to healthcare, the things that we saw with efforts to repeal the ACA. And one of the things that I heard from the three of you in different respects is how there have been more subtle attacks that haven't been as obvious. So for example, I think using 1115 waivers is a really good example, or Maxx talked about folks not realizing that they were unenrolled. And so I was wondering if you could talk about, one, if someone is new to this space, how do they go about finding out that these things are happening? And then two, do you have one or two strategies that are effective, that you found really effective in pushing back and making your voice heard?
So I'll take a quick stab at it. You have to just keep, especially in this day of age, like keeping up to date with it. I get Google alerts on healthcare access, healthcare in the South, HIV, so one of the things that I do is set up Google alerts to make sure that I'm most up to date with some of these things going on. But also PWN, and also for your state, understanding where the state coalitions currently are that are working on healthcare. What is your current, like, do you have Medicaid expansion? What has been the attempts to expand Medicaid in your state? What have been your attempts to talk about other different type of healthcare bills? Sharon had brought up a great, one of the things that are happening right now in Georgia, and there is a division of folks on both sides of how we should move forward with some of the bills moving with Georgia and the current administration. The other piece to me is knowing your story. knowing your own personal story and also stories of people that have had people that are close to you, family, community members, how healthcare is impacting. All of us have different stories to be able to tell that, and being able to share that story and be honest on how to tell that story is truly important, and also changes legislators' minds, communities' minds, and being able to move folks around it. So being very key of like how it looks in your state, what's going on, and keeping up to date with that, both federally, but also like locally for yourselves. And then also being able to truly tell your story. The first two things I think that are really important for us to actually change healthcare.
One thing that the National Medicare for All movement is doing, which I think is really exciting, anchored through National Nurses United, is a push for, they held organizing meetings, 150 all over the country, that brought people together. They call them barnstorms, and thousands of people came out to these meetings to learn about the issue, figure out how to plug in. But it was mostly about getting folks to commit to canvassing and phone banking events. You may very well find an event near you in the next couple of weeks, which would be a fabulous opportunity to plug in. And if there isn't one near you, you can go through a training. They have great materials, great support folks. And so I agree with Maxx. For those of us who are passionate about it, staying up to date with Google Alerts. But one thing we talk about too is that we know from our own lived experiences, we don't have to be policy experts. You don't have to have an MPH to know that healthcare is messed up, and then we got to get organized and go out and talk to our neighbors to fix it and make sure that our legislators are hearing from us. So MedicareForAll.org will have great ways for you to plug in.
Yeah, I'm going to just echo Max's comments about, I think, especially when I was new in this space in Utah as a healthcare advocate, I really, I just graduated from college and I had my own personal experiences with healthcare and accessing healthcare, so did my family. But in terms of figuring out what the policies were in play in Utah, it was like really through my work of, getting to know like the local health policy people, and also in my work just reaching out to refugee and immigrant communities and understanding what their needs were and really listening to their stories, right? So I think that's important, is just to start meeting with whoever wants to talk to you about healthcare policy or healthcare or the concerns that they're having. And I want to echo just really being really being engaged at the state and local level, because there's a lot of stuff going on at the federal level, but we know from Max's presentation and Katie's presentation too, right, that there's a lot happening at the state and local level, and that work will inform what's happening at the federal level. And I think in terms of tactics are important. I think just sharing your story is so important, regardless of whether it's at a public hearing or whether you're submitting an administrative comment to the state Medicaid agency or you're at the Department of Health and Human Services. As Katie mentioned, like and I'm always telling people this, like you do not have to be an expert in Medicaid to like weigh in on these issues or any other healthcare issue. Your story is the expertise, right? So you know what's wrong with the healthcare system. And so it's just equally important to, write those little short paragraphs to the Department of Health and Human Services.
Hi, everyone. There was a little bit of a technological error, and so we unfortunately got cut off a little bit on the end of Candace's response. But I wanted to make sure that before we ended, you all got a chance to see some of the resources, as well as look at our upcoming webinars to look forward to and register for. So here you'll see we have a list of resources for you. We have the fact sheet that PWN had mentioned on universal healthcare that we are launching just today. It's very exciting. I hope you'll check it out. And I especially recommend looking at the recommendation section so you can know some of the concrete policy objectives that you can act on. We also have recommendations in our universal healthcare section of our policy agenda. You'll see we have an article up here by the Treatment Action Group. One of our presenters, Maxx, co-wrote this article, so I suggest you check it out. And we have a couple of resources from NHELP that Candace recommended for us: Medicaid and Reproductive Justice, and Medicaid Demonstration Waivers and Reproductive Justice. So these can help inform your advocacy around the Medicaid program and 1115 waivers that we talked about a little bit before. I also hope that you will mark your calendars. So we do have, this is the second webinar in our series. So we have 4 that are coming up in the coming months. We have Advancing Economic Justice, Ending Violence Against Women Living with HIV, Advancing Sexual and Reproductive Health Rights and Justice, and Advancing Trans Rights, Safety, and Justice. So you can see the dates up here. You can see the registration links. So I hope that you will click on those links and register, and we will see you in the coming months to learn more about the PWN policy agenda and to talk with some leaders in the field. So all of this is to say thank you so much to our presenters today. Candace, Katie, Maxx, this would not have been possible without you. It was an amazing discussion and we appreciate you so much. Thank you to everyone who came out, who participated, who listened. Thanks to all of you who I know are going to use those resources to get your advocacy off the ground, especially as 2020 is coming up, as we have heard numerous times on this webinar. Voting has consequences, and so I'm really looking forward to ramp up for the 2020 election. A big thanks to Nana as well, the co-facilitator, co-moderator on this webinar. I hope that everyone has a great day, and I look forward to seeing you all on our Economic Justice webinar. Have a good one.